Music is not coming.
Ma'am, please share again.
Earlier the music came.
Ganguly sir, here I tried, music is not coming. Can you please do it? Yes. Good evening to all the respected dignitaries, my seniors and colleagues. I, Dr. Neha Singh, editor of Raigad IIP and secretary AHA Raigad. On behalf of my IIP and IIP Raigad, I welcome you all today on 1st of May, celebrated as International Workers' Day or Labor's Day globally. Also today is celebrated as Maharashtra Day, the day of formation of Maharashtra in 1960. And yes, today we also have a journal reading day, which is the first of each month. I welcome MahaIP President Dr. Sanjay Pakmuri sir, Secretary General Dr. Amol Pawar, State Convener Dr. Sanjay Deshmukh sir, MahaIP President 2022 Dr. Hemant Gangolia, Dr. Praveen Gokhale, Dr. Meenaksh Sheikh, Raigad IIP President Dr. Vikas More, Secretary Dr. Ajay Kohli, respected Dr. Neeman Mohanty sir, Dr. Chitra Kulkarni ma'am, and all the respected executive board members from Central IIP, Maha IIP, Raigad IIP, as well as all branches. I would also like to welcome Dr. Srinivasan sir for today's journal journey. I'm extremely pleased to welcome our esteemed experts of today, Dr. Sameer Dalwai sir, who in spite of being so busy, found a time from his schedule for being our expert for today's journal. And also Dr. Pawan Deore sir for accepting our invitation for being expert for today's journal journey, as well as our presenters, Dr. Nilima Bhandarkar ma'am and Dr. Poonam Maqsood. So now I invite Maha IP President Dr. Sanjay Pakmore sir to please give his blessings. Over to you, sir. Sir, kindly unmute yourself. Sanjay sir, kindly unmute.
सॉरी. नमस्कार. सर्वप्रथम सर्वांना आज महाराष्ट्र दिनाच्या हार्दिक शुभेच्छा आणि लेबर डेच्या पण हार्दिक शुभेच्छा. जर्नल जर्नी हा दर महिन्यात पहिल्या तारखेला जो सेलिब्रेट केला जातो, मला असं वाटतं त्यातले हेही कारण असावं ठळक महत्व की 1 मेच्या दिवशी सुद्धा महाराष्ट्र डे येतो. म्हणजे वर्षातून दरवर्षी महाराष्ट्र डे हा जर्नल जर्नीच्या दिवशीच येणार, हे प्रामुख्याने येणारच. तर योगायोग म्हणावा की काही असो, चांगला योगायोग आहे. तो आज आपल्या उपस्थित असणारे आजच्या या जर्नल जर्नीच्या प्रोग्राम मध्ये जे मोठ्या मेहनतीने या कार्यक्रमात म्हणजे या कार्यक्रमासाठी रायगड आयपीला मी धन्यवाद देतो. त्यासोबत डॉक्टर नीमन मोहंती सर जी बरीच मेहनत करतात या प्रोग्रामला समोर सुरू ठेवायसाठी किंवा या प्रोग्रामला मागच्या 3-4 वर्षापासून सतत आणि अतिशय आवडीचा प्रोग्राम असा म्हणून हे म्हणजे सर्वांनी जेवढेही 2-4 मागच्या वर्षीचे 4-5 वर्षाचे प्रेसिडेंट झाले त्या सर्वांनी हा प्रोग्राम आपल्या कारकिर्दीत सुरू ठेवला. त्याचा मला आनंद वाटतो कारण तो प्रोग्रामच तसा आहे आणि म्हणून माझ्या कारकिर्दीत मी तो सुरू ठेवायचा असं मी विचार केला. मला असं वाटतं की भविष्यातील लोक तो प्रोग्राम सुरू ठेवणार कारण रायगड ब्रांच बरीच कर्तृत्ववान ब्रांच आहे, बरीच खंदे कार्यकर्ते त्याच्यात आहेत. त्याच्यामुळं आणि अतिशय ज्या हिशोबाने हा कार्यक्रम सेलिब्रेट केला जातो, त्याच्या मागे जी मेहनत केली जाते ती खरंच अतिशय म्हणजे त्यांचं मूल्य या कार्यक्रमाबद्दल जे मौल्यवान म्हणजे त्यांच्याकडनं जे एफर्ट्स येतात ते खरंच म्हणजे मोलाचे आहेत. आणि आज या जर्नल जर्नीच्या प्रोग्राम मध्ये आपल्याला जे उपस्थित लोक जे व्यक्ती आहेत, सर्वप्रथम मला त्यांचं मी आभार मानतोय. तर डॉक्टर निमन मोहंती सर, नंतर प्रेसिडेंट 2022 महाराष्ट्राचे माजी प्रेसिडेंट डॉक्टर हेमंत गंगोलिया सर, नंतर महाराष्ट्राचे कन्व्हेनर डॉक्टर संजय देशमुख, आणि सेंट्रल IIP जे EB मेंबर्स आहे डॉक्टर प्रवीण गोखले, डॉक्टर दीपा फिरके मॅडम, डॉक्टर राजेश कुलकर्णी, डॉक्टर संजीव जोशी, आणि आजच्या या कार्यक्रमासाठी महाराष्ट्र EBचे जेवढे लोक आज जॉईन झालेले आहेत, आणि सोबतच या कार्यक्रमाचे प्रेझेंटर्स आणि कार्यक्रमाला मॉडरेट करणारे डॉक्टर नेहा सिंग, आणि सोबत चित्रा मॅडम असतात नेहमी, पण उद्या नर्स मॉड्यूल सकाळी नागपूरला आहे आणि आम्ही सुद्धा त्याच्यात इन्व्हॉल्ड आहोत. महाराष्ट्र IIP पण इन्व्हॉल्ड आहे. उद्या चित्रा मॅडम तिकडे असणार म्हणून कदाचित त्या आजच्या प्रोग्रामला नाहीत. आणि आताच नेहाने सांगितल्याप्रमाणे आपल्या वेळात वेळ काढून आलेले महाराष्ट्राचे भावी अध्यक्ष, म्हणजे महाराष्ट्राचे CIPचे अध्यक्ष, ज्यांना आपल्याला महाराष्ट्रातनं निवडून द्यायचे, आजच्या दिवशी प्रण करूया की त्यांना मोठ्या मताने आपण CIPच्या इलेक्शन मध्ये महाराष्ट्रात निवडून द्यायचं आहे. तसं मला सरांना सांगावंसं वाटतं की माझा पायगुण चांगला आहे. खडतकर सरांच्या वेळेस मी बोललो होतो की मी प्रेसिडेंट नागपूर असताना निवडून आलेत. तसं समीर सर तुम्हालाही सांगतोय की तुम्ही काळजी करू नका, तुम्ही नक्कीच निवडून येणार. नंतर डॉक्टर मिन्हास सर, सायंटिफिक चेअरपर्सन, जे बरीच मला मदत करतात प्रत्येक सायंटिफिक प्रोग्राम मध्ये. बऱ्याच वेळी मी त्यांचं नाव घ्यायला विसरतो, पण ते कधीच वाईट मानत नाही, कारण त्यांना माहिती आहे की सर नेहमी माझ्या हृदयात असतात. त्याच्यामुळे नाव चुकलंय तरी नाव घेतलं जातं, असं त्यांच्यापर्यंत पोहोचून जातं. तर आजचे हे 2 टॉपिक प्रेझेंटर जे निलिमा भांडारकर मॅडम आणि मस्तूद मॅडम, आणि एक्सपर्ट्स आपले समीर सर आणि डॉक्टर देवरे सर, या दोघांचे मी आभार मानतोय. पहिला जो टॉपिक आहे की एव्हिडन्स बेस्ड इंटरव्हेन्शन्स इन ऑटिझम, या मागच्या महिन्यात ऑटिझमवर बरेच प्रोग्राम्स घेण्यात आले. सरांनी बरेच टॉक्स दिले. प्रत्येक वेळी सरांनी सांगितलंच की नुसती थेरपी करावी लागते हे म्हणण्यापेक्षा कोणती थेरपी लागते, कोणत्या बाळाला कोणती थेरपीची गरज आहे, हे जास्त महत्वाचं असतं. तसंच हे थेरपी कंडक्ट करताना नुसतं पेशंटच महत्वाचा नसतो, त्याच्यासोबत त्याचे आई वडील, पेरेंट्स, हे सुद्धा अतिशय महत्वाचं असतं. त्यांच्या लूपमध्ये त्यांना ठेवल्याशिवाय कोणत्याही थेरपीला काहीही महत्व नाही, हे मागच्या 1 महिन्यात सरांकडनं मला समजलं. नंतर दुसरा टॉपिक की ब्रेस्ट फिडिंग आणि नेफ्रॉटिक सिंड्रोम. आता ब्रेस्ट फिडिंग तर प्रत्येक ठिकाणी मदत करते आणि ब्रेस्ट फिडिंग इज द बेस्ट फिडिंग, हे सर्वांना माहितीच आहे. ब्रेस्ट फिडिंगचे काय काय फायदे सांगायची गरज नाहीच. आज जेव्हा टॉपिक वाचला ब्रेस्ट फिडिंग आणि नेफ्रॉटिक सिंड्रोम, तेव्हा पहिल्यांदा असं वाटलं की असं कधी मनात आलंही नाही, असं कधी टॉपिक याच्यावरही स्टडी आहे म्हणून. परंतु आज ब्रेस्ट फिडिंगचे फायदे खूप सारे आहेत. त्याप्रमाणे ब्रेस्ट फिडिंग आणि नेफ्रॉटिक सिंड्रोम मध्ये असा मोठ्याने 20% रिडक्शन ऑफ द रिस्क आढळून आले. म्हणजे ब्रेस्ट फिडिंग मध्ये त्याच्यातही त्याला मदत होते ऍज कम्पेअर केलं आपण वरच्या दुधापेक्षा, गाईचं, डब्याचं. आणि ब्रेस्ट फिडिंग मध्ये फक्त ड्रग्ज वर असताना काय ड्रग्ज मदरला चालू असतील तर बाळांपर्यंत पोहोचू शकतात, त्याची काळजी घ्यायची असते. बस बाकीचं आपण एक्सपर्ट कडनं ऐकूया ते काय म्हणतात आज दोन्ही टॉपिक्सवर. सो सर्वांना एक परत या मंचावर मी आपल्याकडनं अभिवादन करून तुम्हाला आमंत्रित करतोय. धन्यवाद.
Thank you, Sanjay sir, for all your blessings and giving us the MahaIP platform. So now I invite MahaIP President 2022, Dr. Hemant Gangolia sir, to say a few words and give his blessings. Over to you, sir.
धन्यवाद नेहा मॅडम. सर्वप्रथम सर्वांना नमस्कार. आणि आज महाराष्ट्र दिन व कामगार दिन या निमित्ताने सर्वांना हार्दिक शुभेच्छा. शिवाय आज उपस्थित IIP रायगडचे पदाधिकारी, MahaIPचे पदाधिकारी, शिवाय CIPचे जे पदाधिकारी आहेत, इथे एक्सपर्ट्स आणि प्रेझेंटर्स जे आहेत त्यांना सर्वांचं ह्या कार्यक्रमामध्ये स्वागत आहे. आणि मला अतिशय आनंद होतोय की जेव्हा प्रवास बघतोय ह्या जर्नल जर्नीचं, गेल्या 3.5-4 वर्षापासून सुरू केलेला प्रवास हा अतिशय सुरळीतपणे आणि व्यवस्थितपणे चालत असताना, आणि आपण बघत आहोत की आपल्या राज्यातले प्रत्येक जवळजवळ सर्व जे IPA ब्रांचेस आहेत सर्वांनी सहभाग केलाय, आणि हे गेल्या 2 वर्षात आपला महाराष्ट्र सोडून इतर राज्यात सुद्धा प्रेझेंटर्स व एक्सपर्ट्स आलेले आहेत आपल्या या कार्यक्रमासाठी. त्यासाठी मला खूप आनंद होतोय. आणि मला तो दिवस आठवतोय जेव्हा पहिला एपिसोड झाला होता, तेव्हा मी प्रेझेंटर म्हणून हा एक प्रेझेंट केलं होतं. तर ती आठवण झाली मला. आणि शिवाय जे पण आपले पदाधिकारी आहेत, ज्यांचे पुढचे जे काही आपले जे काही आहे, त्यांना सर्वांना शुभेच्छा. आणि आजचे जे संवादक जे आहेत, मॉडरेटर्स आणि आपले एक्सपर्ट्स आणि जे प्रेझेंटर्स, दोघांनाही ऑल द बेस्ट विशेस. आणि मला वाटतं हा कार्यक्रम चांगलाचपणे होणार आहे. आणि शेवटी आपण खूपच आपल्याला डॉक्टर निमेन मोहंती सर, ज्यांच्या शाळेत ते मला वाटतं ते जॉईन झालेले आहेत. आणि आपलं सौभाग्य आहे की आपले टीचर्स ऑफ टीचर्स डॉक्टर श्रीनिवासन सर सुद्धा उपलब्ध आहेत तिथे. आणि शिवाय संजय देशमुख, मीना शेख आणि आपण सर्वजण हजर असताना हा कार्यक्रम नक्कीच आपण खूपच शिकणार आहोत, जे काही 2 शेअर होणार आहेत. आणि जर्नल जर्नीचा प्रवास असंच सुरू राहावं आणि पुढे जावं आणि यशस्वी व्हावं, त्यासाठी हार्दिक हार्दिक शुभेच्छा. धन्यवाद.
Thank you, sir, for your encouragement and blessings. Now I invite Sanjay Dekshmukh sir to say a few words. Over to you, sir.
नमस्कार, शुभरात्र. सर्वप्रथम महाराष्ट्र दिनाच्या सर्वांना हार्दिक शुभेच्छा, लेबर डेच्या शुभेच्छा. महाराष्ट्र बालरोग संघटनेचे सर्व पदाधिकारी, रायगड जिल्ह्याचे बालरोग संघटनेचे सर्व पदाधिकारी, सायंटिफिक चेअरपर्सन्स आणि त्यानंतर आपल्या अखिल भारतीय बालरोग शाखेचे सर्व पदाधिकारी, मी डॉक्टर संजय देशमुख तुमचं सर्वांचं स्वागत करतोय. जनरल जर्नी हा खरंच एक कौतुकाचा उपक्रम आहे. त्याद्वारे आम्हाला नवीन नवीन विषय रायगड टीमच्या मार्फत डॉक्टर मोहंती सर यांच्या मार्गदर्शनाने आम्हाला दर महिन्यामध्ये आम्ही वाट पाहतो. आणि आजचे जे दोन्ही टॉपिक जसं आमचे अध्यक्ष पापमळे सरांनी सांगितले आहे, दोन्ही एक्स्ट्रीम टॉपिक्स आहेत. एक तर ऑटिझम मागच्या 1 महिन्यापासून जो उपक्रम महाआयपी घेत आहे, आय थिंक त्याचा आजचा हा समारोपाला एक विषय राहू शकतो. आणि डॉक्टर पूनम, डॉक्टर समीर दवे सरांच्या मार्गदर्शनाखाली आपल्याला नवीन काहीतरी एव्हिडन्स बेस्ड ऐकायला भेटणार आहे. त्याशिवाय वेगळाच टॉपिक ब्रेस्ट फिडिंग आणि इन्सिडेन्स ऑफ नेफ्रोटिक सिंड्रोम. खरंच मी सुद्धा विचार केला नव्हता आणि खरंच ते सुद्धा आपल्याला आज डॉक्टर निलिमा भंडारकर मॅडम सुद्धा आपल्याला अपडेट करणार आहेत. तर माझी सर्वांना शुभेच्छा आणि हा प्रवास असाच सोयीस्कर चालवत राहो याबद्दल मला खात्री आहे. धन्यवाद.
Thank you, sir. So now I invite my colleague, AHA Raigad Treasurer, Dr. Shilpa Nambiar Gandhi, to please introduce the presenters and experts of today. Over to you, Shilpa.
Thank you, Neha ma'am. Good evening, everyone. A very happy Maharashtra Day to all. So I'll just quickly introduce our experts and presenters today. So our expert for today, Dr. Sameer Dalwai, sir. Sir is a developmental and behavioral pediatrician, the director at New Horizon Child Development Center. Sir has held various positions in the Central IAP. Sir has been the treasurer in 2022-23, joint secretary 2020-21. Sir has been editor-in-chief of IAPA Handbook of Developmental Pediatrics. Sir has been faculty of national and international conferences and also received Rajiv Gandhi Manav Seva Award from the Government of India. Our second expert for today, Dr. Pavan Deore sir, is consultant pediatric nephrologist at Kids Kidney Clinic Nashik and assistant professor at Vasantrao Pawar Medical College. Our two presenters today, Dr. Nilima Mandakar ma'am, Ma'am is a practicing pediatrician in Panvel for the last 25 years. Ma'am has also been the secretary of Raigad IIP 2021 and treasurer AHA Raigad. Our second presenter for today is Dr. Poonam Mastood ma'am. Ma'am is a practicing pediatrician and director of Max Multi-Speciality Hospital, Solapur, and practicing since the last 10 years. Quickly moving on to our presenters, Nilima ma'am, can you please share your slide, and we will start with our first topic, the topic being evidence-based interventions in autism.
Thank you, Dr. Shilpa. Good evening, everyone. We'll straightway go to the presentation.
We request our attendees to please post their queries in the chat box. At the end of both the presentations, we will be taking them if there is time. And sorry, ma'am, please, you can share your Instagram.
Yeah. Can you see the slide in full screen?
No.
No? 1 minute, huh?
Slides are not shared, ma'am.
एक second.
Oh.
आता दिसते मॅडम, आता होते आले.
Slide show.
Right.
Kindly make it full screen, madam.
Slides show.
Yeah.
Yeah, that's it.
Can you see now in full screen?
Yes, ma'am. Yes, ma'am.
Yeah. So today I'm going to present some facts from the article. The name of the article is Evidence-Based Interventions in Autism. This article is published in Pediatric Clinics of North America in 2024, and the authors are Julia Annixt, Jennifer Erdart, and Amy Duncan. Now, this article is basically a review article, and it is reviewing, or it is taking into account 2 other review articles. One of the article is National Standards Project, which is published in 2015 by National Autism Center. And second is Evidence-Based Practices Report, published in 2020 by University of North Carolina Autism Evidence and Practice Review Team. So you can see that there are 2 review articles, and this article is reviewing these 2 articles. So basically this article is like guidelines for general pediatricians or primary care pediatricians practicing in the USA. Crucial role of the general pediatricians in screening for autism and other developmental disorders as they are the first touch point for the babies. They are involved in the long-term care of the children with ASD. Each child has different strengths and weaknesses. So all children with autism are not having same set of symptoms or strengths, weaknesses, and each family has different priorities and abilities. Primary care pediatrician can take into account all the things related to family and the child's strengths, weaknesses, and guide the child and family about the intervention at the earliest. The importance of early intervention is autism can be diagnosed below 2 years at the earliest, and it is desirable that we diagnose it by 3 years. Why it is important? Because brain is still developing and has much more plasticity, so you can have better impact. Early interventions improve outcomes substantially when we start early. That's why the message for primary care pediatricians is never say wait and see if you suspect autism in a child. Now, federally mandated intervention and services in the USA. Basically, this article tells you about what are the services offered in the USA for babies with autism. Federally mandated are supported by government. Under the rights of the child and rights of persons with disability, federal funding is given to the states for early interventions from birth to 3 years and special education services from 3 to 21 years. It includes autism, intellectual disabilities, speech impairments, and many more developmental disorders are covered under these programs. Now, evidence-based interventions are, these interventions are offered to children with autism according to the child's developmental level. There are two basic categories. One is called as CTM, that is Comprehensive Treatment Model, which is focused on the broad outcomes. And it is given to all 0 to 9 years kids. And the second category is evidence-based practices, which are focused interventions, which are offered to all age groups. Now we'll see one by one. CTMs, that is Comprehensive Treatment Model. It is focused on broad outcomes like social communication and behavior from 0 to 9 years. Procedure with high intensity, that is there are more number of hours every week, and longevity, that is the program is continued for more than 1 year. Examples of this comprehensive treatment models are EIBI, that is Early Intensive Behavioral Intervention, ESDM, that is Early Start Denver Model, ABA, that is Applied Behavioral Analysis, and last one is Naturalistic Approach, that is intervention is given at the natural environment like home or school. The second category was evidence-based practices. These are offered for all ages. Specific strategies are used to teach an individual skill or a specific goal. Many EBPs together, that is many evidence-based practices together, form one IEP. IEP stands for Individual Education Plan, which is for a single child or a single patient. Examples of EBPs are prompting, gestural cues, visual support, and many more. It can be used for short period till specific goal is achieved. So CTMs were for broad outcomes, evidence-based practices are for specific goal and short term. Besides these two government-supported therapies, there is one another category which is called as outpatient therapies. Now, obviously, these are offered to the kids at some charge and parents are to bear those charge. In addition to federally mandated school or family-based programs like CTM and EBPs, occupational therapy, speech therapy, behavioral therapy, etc. are offered. Parental involvement is crucial in this. Travel distance, cost which is borne by parents, and availability of specific therapists pose hurdles for many kids. Now, one by one, a little bit about all those interventions. ABA stands for Applied Behavioral Analysis. It is general learning theory and not a specific set of interventions. Principles of ABA are the basis of most treatment models of ASD in the USA at least. It can be center or home based, 1:1 or in group, and certified behavioral analyst plans it. Second intervention is EIBI, that is Early Intensive Behavioral Interventions. There is evidence that 20% to 50% children participating in EIBI achieve average IQ and are placed in regular schools. 20% to 40% show improvements but continue to need support lifelong. And the last one was naturalistic developmental behavioral interventions. Natural environment like home, school, or community. Back and forth engagement between the child and caregiver is provided. Cues are provided to the child to promote desirable behaviors, and parent-mediated interventions involve parental training for implementing these strategies at home. Now, which are the areas in which interventions are provided? The first one is social communication. As you all know, autism is basically the child is having difficulty in communication. Interventions for improvements in communication are provided by speech and language pathologists, psychologists, or even OTs, that is occupational therapists also can do it. It is incorporated in CTM, that is their government-backed program, which is offered for 0 to 5 years. These children can be taught to communicate with alternative and augmentative ways as well, in addition to verbal means. So sign language, PECS, that is Picture Exchange Communication System, SGD, that is Sound Generating Device, all these methods can be used or taught to the child. Contrary to usual parental concern, these ways do not prevent or delay the speech. Social communication continues further. In children below 5 years, evidence has shown that eye contact, imitation, gestures, joint attention, and play are moderately helpful. In older children and adolescents, some interventions and additional social intervention package is offered, which is helpful. This additional social intervention package is in short called as PEERS, that is Program for Education and Enrichment of Relational Skills, is a manualized social skill intervention package for both adolescents and their parents. It is given for 14 weeks. It involves peer-mediated interventions also. The second area in which interventions are offered is adaptive behavior. This is ability of an individual to be self-sufficient in the areas of social communication and activities of daily livings. ADLs are the tasks to take care of themselves at home, school, work, and community. It starts from brushing, bathing, eating, to using concepts of time and money. So it's a big spectrum. Psychologists, OTs, special educators are intervention providers. Below 5 years, prompting, family coaching, and positive reinforcements are used. And in older child, task analysis, rewards, technology like alarms, reminders, etc. are used. Another area in which interventions are provided is behavior and mental health interventions. Many challenging behaviors are seen in ASD children, like tantrums, refusals, irritability, aggression, self-injurious behavior, etc. 70% of autism spectrum kids have comorbidities like attention deficit hyperactivity disorder and psychiatric disorders. So in these cases, FBA, that is functional behavioral assessment, is necessary to identify ABCs. What is ABC? Antecedent, behavior, and consequence. In short, the problem behavior. Suppose the child is showing aggression or self-injurious behavior. That behavior is behavior of concern. That is B. What triggers it? That is antecedent. So you have to identify the trigger or the situation preceding it. And C is consequence. What happens after that behavior? So you have to analyze the child's behavior in this way. Evidence shows parent training is most useful for challenging behaviors. For older children, cognitive behavioral therapy is useful, very useful for anxiety disorders, both in neurotypical and autism spectrum kids. In CBT, participants are taught to evaluate their thoughts and emotions and then apply step-by-step strategies to change their thinking and hence behavior. One more area in which interventions are needed are executive functioning. Now, older children with ASD and ADHD, they face challenges in executive functioning like planning, organization, time management, multitasking, and so. Interventions in the form of graphic organizer, use of technology like alarms, reminders, task analysis strategy, all these things are taught to kids so that they can handle these executive functions. Parental involvement is essential and very important. Another area for interventions is sensory processing. You might have seen many kids show sensory difficulties. So hypo or hyper reactivity to usual sensory inputs and unusual sensory interests are seen in ASD children. It presents like specific food preferences. Some kids may like soft, mushy foods. Some kids may like crunchy food. Some show garment or shoe selectivity. They are showing sensitivity to loud noises, etc. So these all interfere with the daily functioning of child, and occupational therapist is the key person to provide interventions in this area. So in summary, children with suspected autism should be referred to diagnostic evaluations and early interventions as soon as possible. Starting evidence-based early interventions at a younger age, that is as early as possible means less than 3 years, is associated with greater positive impact on outcome. CTM interventions are proved to improve core autism symptoms, cognitive abilities, communication skill, adaptive skills, behavior, sensory processing, and even mental health in children with autism. Pediatricians play important role in advising families about evidence-based interventions, considering child's strengths, weaknesses, and families' priorities. What this study adds to our knowledge? This article gives us an overview of how children with autism are managed in the US. State government, with the help of federal funding, provides interventions from 0 to 3 and 3 to 21 years. Additional outpatient therapies are offered at cost. It emphasizes importance of general pediatricians knowing about autism and the interventions offered. Interventions are offered for social communication, behaviors, mental health, sensory issues, etc. There should be no one size fits all approach, that it should be customized, and it emphasizes earlier the better. Now some queries or suggestions or some remarks on the article. The article tells about interventions offered for various symptoms of autism, but it does not tell you what is the basic cause of different symptoms in children with autism, and hence the general pediatrician will never know how to plan the treatment. Article does not discuss level of improvement with specific intervention. It is not clear if some children with autism, at least few of them, show complete improvement in core ASD symptoms. There must be some non-evidence-based interventions in vogue or in practice in USA also. The article does not specify those. So there is no comparative between evidence-based and non-evidence-based. Further research is needed in the area of comparative study of interventions offered in different countries. So this is related to USA only. There are two cases mentioned in the article at the end. The first case is a 4-year boy diagnosed with autism spectrum disorder and global developmental delay at the age of 2 years. Minimal verbal language, no toilet training, sensory aversions, transitions, any type of transitions causing meltdowns and constipation is there. He is enrolled in EI, that is early intervention from the age of 18 months, plus occupational therapy, speech therapy, EIBI, all these things are offered. Frequent meltdowns at school and home is the current concern. Now, the suggested therapies or suggested interventions in this article are stool softener, referral to OT and psychology for feeding issues, referral to speech therapist, continue EIBI, parents to discuss strategies used in school so as to extend those at home, written schedule as visual support so that transitions will be mentioned in that and there won't be meltdowns. So this was case 1. The second case is of an older child. He is a 10-year boy diagnosed with autism spectrum disorder plus hyperactivity at 4 years, and he likes video games. He is currently on stimulant medications in school EIP, that is individual education plan, speech therapy and occupational therapy. Cognitive abilities are low average, needs assistance in ADLs, that is activities of daily living. Reading comprehension difficulties are there, executive functioning difficulties are there, cannot make friends as difficulty in back and forth conversation, yells or cries when feeling overwhelmed or demands are not met. Now the suggestions given for this boy are continue your IEP, occupational therapy, speech therapy, ask about specific intervention for reading comprehension, play dates with peers, occupational therapy for, again, activities of daily living, continue extracurricular activities like baseball, refer to psychologists for strategies to manage emotions. So these are the two cases. Thank you.
Thank you, Nilima ma'am.
Thank you, Nilima ma'am. That was a very good article. Now I request Samir sir for the expertise comments. Nilima
Now,
ma'am,
so
you
what?
can stop sharing.
Yeah.
Now, so what
Okay,
am I
okay.
expected to say and for how long?
Sir, you can take your time. No problem, sir.
No, but what am I expected to say? As in comment on the article or what? So I'll
On the
keep it that
article
way.
first, sir.
All right. So I'll just tell you a few of the things. First and foremost, this is an American article because it is Pediatric Clinics of North America. And as she said in her first slide itself, this is the US method, federally mandated, matlab the government pays for it. So it is very clearly something intended for children living and who are, sorry. Sorry about that. Can you hear me?
Yeah.
Yeah, this is about children living in the US and how the government should pay for it to have the children in US better. So it's very clear it is about US children. What we must understand is if we are discovering some new method for MRI, something based on technology or something based on a new molecule for a particular malignancy, we don't have the technology for that. But the US has better technology, better research method. And if it is a malignancy, then the malignancy is the same kind of medication that is used there will obviously work for a person in India. But when it comes to mental health, the most important criteria of mental health is the socio-cultural issue around the person. Because mental health is a culmination of the child's genes and what the child has gone through in social experience from birth till this day. It is not common or same to each person in India, and it is certainly not common as a group between Indian or India as a race and the US as a race. Because our socio-cultural practices are completely different from their socio-cultural practices. So when we talk about evidence, what is the evidence for? Is the evidence that with doing OT, my child can do shape sorting better? Can my child do color mapping better? Can my child match squares better? Yes, there is evidence for it. Then there can be evidence that my sitting tolerance gets better. But when my child is doing shape sorting or color matching or matching puzzles, where is the evidence that this child can live in society normally? In India, I would
Yes.
ask, where is the evidence that this child has sitting tolerance with the Masi, Chachi, Kaki, neighbor, everywhere else without the mother? Nobody will even think of this research in the US because they don't have a Chachi, Masi, Bua, Mami. Then why do they do this? Because the parents have to go to a job. There is nobody else to take care of the child. Even if he has to go to a preschool or a school, somebody has to keep that child busy so that the other children can go on with their normal life. So what can I do to control this child or contain this child? I can give him shift sorting. So then the rest of my class can go on. But who will give this child shape sorting? A shadow teacher or a special teacher. Where will this funding come from? I will go and raise a flag and fight so that the government mandates that. So now it is taken care of. Parents are at work. They are going on with their life. Child has gone to school. So the whole world thinks the child is in school. In school, the child is doing nothing what the other children are doing. But the child is being looked after by a shadow teacher or by a remedial educator who is providing whatever the child needs to keep the child occupied so it doesn't disturb the other children the government is paying for. So everybody is happy. That's why in the cases also that you saw, the
Yes.
10-year-old child was anyway doing OT speech therapy.
Yeah.
But even now, he's not being able to manage the class. He can't do his ADLs. He can't live
He
independently.
can't live
So
with it.
what is this treatment now? Continue doing OT speech therapy.
Continue.
So this is a model for maybe an American country where there is enough resources and money to be pumped into importing therapists from India and telling them keep doing shape sorting, color matching, keep saying mama, mama, mama. So the child will develop echolalia and keep saying mama. So everybody's happy. But it will not work for a country like India because we are trying to copy them, though our socio-cultural situation is completely different from that. So that is the first fallacy. The second fallacy is the US looks at autism as a collection of symptoms. Basically, the word autism means is defined as or diagnosed as having tick boxes for child with poor eye contact, does not respond to name call, does not know how to behave well, does not understand spoken speech, does not speak well, speaks repeatedly, and does the same activities repeatedly. If you have these 7 symptoms in a child, it is actually a syndrome like a Kawasaki, high grade fever, rash, etc., etc. But that is a syndrome. We were understanding Kawasaki syndrome to look at research, and eventually we came up that it's an autoimmune modulated thing. And now we have a immune therapy or whatever else we do with immunoglobulins, etc., to treat the cause. Here the situation is for 85 years, we have kept the symptoms only and we are treating only the symptoms. So it is like you have a Kawasaki today, tick box. So yes, Kawasaki as a diagnosis, but you keep giving paracetamol for the fever. You keep giving some anti-allergic for the rash. Of course, the fever will come back the next day. So after 10 years of OT speech therapy, the child is still not normal. You keep giving speech therapy and occupational therapy. So now he has rash, so you give an antihistaminic. Now he has an educational problem. So you start giving some educational intervention, like she mentioned in case 2. So I think this article actually typifies how the US has misled the world in doing the wrong things. And this article is an evidence that they have failed, but how they are using these wonderful words like evidence-based medicine. Is there any evidence that that child can go and live normally in society? What do you want for any child? Of course, for a child with malaria, you want him to be malaria free. A child with tuberculosis, you want him to be tuberculosis free. A child with autism, you want him to live in society independently with other people without needing specially trained people to look after the child, which is not possible in a country like India. Where is the evidence for that? Is there one article that this review article pulled out that this showed that by doing this method, they enlisted 10 methods, ABA, there is
Yes.
early start Denver model, EIBI, PQR, ABC, whatever, natural development. हे केल्याने एवढी मुलं समाजात नॉर्मल राहिली, त्यांचे आई बाबा वर गेले आणि ही मुलं तरी सुखात राहिली, समाजात चांगले करत होते. एकही आर्टिकल नाही. So what this evidence-based medicine tells us is create patterns around the child. Because children with autism, because of this theory, which I believe is right, I may also be wrong, Vastu Magnata, they are more pattern learners. So create patterns around the child, create a patterned ecosystem around the child. If you ask the child, what is your name, says Samir, then the child will repeat, what is your name, says Samir. You say, now speech therapy is working, the child is speaking. But if somebody comes and says, tell me your name, no answer. नाव काय माहित आहे रे नाव सांग मला माहित नाही so somebody has to come and say no you are an insensitive person you don't know how to behave with children with autism you have to ask them like this what is your name and then you'll get an answer what is your name says Samir and this is evidence that if I teach the child what is your name says Samir he will say Samir but it is this way I don't think this is an evidence for anything better. But by using these high-five words, evidence-based medicine, we are able to influence countries like India and put them in a deprivation syndrome mentality. हम तो Indians हैं, हमको क्या research आता है? How will we know? How will we come out with autism? So now they are importing all this rubbish to us after 84 years when they have not been able to find a cure for autism. Neither are their children living in society. And then they're importing this to us by using these big high-five words like evidence-based medicine when it's clearly showing that none of the children are getting better. In one slide, Dilemma showed 20 to 40% children
Yes.
do better but continue to need support.
Continue to need
There's a
support.
slide. Then what did you achieve? And then why are you preaching to the choir? Why are you preaching to the world that do this? And isn't it ridiculous that we are taking these articles as the Gita or the Bible and now trying to teach our people to do this? So finally, I'll conclude by saying this early intervention is a big marketing myth. It means instead of referring somebody at 4 years and he gets therapy from 4 to 14, send him at 2 years. So he gets therapy from 2 to 14. So you get 2 more years of money. Who has shown by starting at 2 years, this child will not need therapy for 14 years or will become normal at 5 years? Nobody has shown. So it is, and what do you do in early intervention? Not one slide said that. Not one point in the article said what you do in early intervention. So basically, every therapist sits with those objects and
Yes.
tries to see what the child can do. What the child can do, you do. What the child can't do, you don't do. What kind of therapy is this? Child comes to with malaria, मी त्याला गोळ्या दाखवते बघ पांढरी गोळी आहे काळी आहे निळी आहे पिवळी आहे तुला कुठला कलर आवडतो मला पिवळी गोळी आवडते डॉक्टर हे पिवळी गोळी खा ह्याने तुला मलेरिया बरा होईल मग मूल शांत बसतं म्हणजे हे बरोबर ट्रीटमेंट झाली का नाही सो इट इज नॉट अर्ली इंटरव्हेन्शन it is early appropriate intervention that we should start using. And how do we know it is appropriate? If the child starts showing normality, if the child starts behaving normally with parents, starts living in the household activities daily normally, is able to help people in the community normally, is able to go to Kaki Mauki's house and live with them without the mother, able to go to school and live normally, and then do academics. If we don't focus on this sequentially, and if we focus on speech also, reading, writing also, before the child has eye contact, it is like teaching a child high jump when he can't even sit or stand. So these are the issues which are going wrong. And I think we need Indian research in our society and we need to start with our goals. What do we want to achieve for this child? In our center and my experience, when the child comes to us, every customer who's paying us money, parent, wants my child should speak so that next month there is a school interview so that he gets admission to school. I don't care about the doctor or the child. He should get into the school and school ka darwaja opens with my child answering some question that the principal asks. So I can train the child. What is your name? Say Samir. What is your name? Say Samir. And then we can do this. But this is not to make the child better. So we must get up and talk that this is not what we want. At our center, we tell the parent, don't come to us for what is your name, say Samir. In our center, we work in 6 months. Can the child stay with Kaki, Maushi, Atya, Mami for 2 days without a mother? If I can achieve that, if not 6 months, 8 months, 10 months, 1 year, at least I'm working on the right goal. Because a child who can stay independently without the mother with relatives, gradually will be able to stay with neighbors and gradually with the school and the school teacher without a shadow teacher sitting on top of his head. So he sits in one place without disturbing the class, like I said earlier. So we need to completely change the dialogue on autism. We need to completely change the way we look at autism. And we need to understand why these articles are being printed. Only एक प्रतिबिंब आपल्या मनावर घडवण्यासाठी की तुम्ही डिप्राइव्ड नेशनचे लोक आहात, डॉक्टर्स आहात, इंडियाचे आहेत, तुम्हाला काय कळतं ऑटिझम काय? आम्ही जे सांगतोय ते करा रे, पण तुम्हाला कुठे कळलं? तुमच्याकडे कॅन्सर बेटर झाला आणि ती औषध आम्हाला दिलीत, तर ती आम्ही चोरी करून पण आणू, हरकत नाही. गरिबी आमच्याकडे, आम्ही ती कॉपी करू. सिपला मस्तपैकी कॉपी करेल कमी पैशात, आम्ही देऊ पेशंटला. अरे पण तुमचे तरी कॅन्सर बरे होतात का? तुमचे जर बरे होत नसतं, मला एवढंच सांगायचं आहे की स्वतः आपण इंडियात हे लक्षात घेतलं पाहिजे की आपण कुठल्या डिप्राइव्ड नेशन मध्ये नाही, आपण सोशो इकॉनॉमिकली वीक असतो. सोशो कल्चरली आपण खूप स्ट्रॉंग आहोत. आपल्याकडे समाज आहे, काकी मावशी आत्या काकी आहेत आणि समाजातल्या लोकांना मुलांचं आहे. तेव्हा वी शुड लुक एट दिस इन अ व्हेरी 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 लिमिटेड लाईट. And this article is important for to tell us probably what not to do. Thank you so much.
What not to do.
सर समीर सर, खरं तर मला
बोला
असं
सर.
म्हणायचं वी शुड डू इंडियन स्टडीज अँड इंडियन आणि मला वाटतं यू मस्ट बी डुईंग ॲट अ सेंटर द
Yes, sir.
स्टडीज अँड thesis so we can put into the journals.
Thank you so much, sir. And thanks to my IP and the Adolescent Academy
Sir,
and Raigad IP for the opportunity.
your blessings and your blessings and whatever you want to say from your side.
That is why Samir sir is so confident in speaking all these things, because he deals with it. He is experienced with that much amount of experience, and then he's delivering. So that's beauty.
Thank you, bhai. Thank you, Sanjay Bhau.
Thank you so much, Samir sir.
Thank you so much for the opportunity.
Samir, you want
Thank
to
you so much.
express something? Samir, you want to express something?
No, thank you so much to all of you, IIP, Raigad, AH, everybody, IIP, MAIP, and Srinivasan sir. It's always an honor to see you around.
Yes.
Minaj sir, Sanjay sir, Sanjay Pakmude sir, all of you, all the seniors. And Hemant bhai, thanks always for being so nice to me. Thank you so much. Shilpa ma'am, and of course, Monty sir, thank you so much for the entire excellent opportunity. Monty sir, thank you so much.
So we'll move on to our next topic.
No, I appreciate your words of wisdom before you go to the next. Thank you. Because you asked my comment, So his words of wisdom is very important. Thank you.
Thank you, sir.
So our next
Dr. Poonam, do you want to, I should share your slides?
Can you share your slides? You want to check once?
Or should I?
Wait, I will try it now.
Yes, madam. Make it full screen.
Is it visible?
Yes, yes,
Yes,
madam.
yes.
Excellent.
You can start with your presentation.
Okay, good evening, one and all. Today, my topic is from Journal of Pediatrics. The name of it is the original article published in Journal of Pediatrics. The article is Association between the exclusive breastfeeding and the incidence of childhood nephrotic syndrome. So as we all know, the WHO and the American Academy of Pediatrics has recommended that the exclusive breastfeeding for the first 6 months of life is very important, because the human milk contains various antimicrobial, anti-inflammatory and immunoregulatory agents which are contributes to the developing immune system of the child. Various extensive studies and meta-analysis has been done, which has shown that the 6 months of exclusive breastfeeding has reduced the incidence of various infections, metabolic diseases, allergic diseases like asthma, some non-communicable diseases such as leukemia, then inflammatory bowel diseases, and type 1 diabetes. Nephrotic syndrome, as we all know, it is the most common glomerular disorder in pediatric population. Most of the cases are steroid responder. In some cases, there is steroid resistance is there, which can lead to, in some cases, kidney failure. Morbidity is mostly due to chronic use of steroid or due to steroid resistance or some immunosuppressive agents, which is responsible for individual as well as social health burden. The etiology of nephrotic syndrome is largely unknown. Majority of times it is thought to involve that there are abnormalities in the podocytes and the glomerular basement, glomerular filtration barrier, which is associated with the immune dysfunction or immune dysregulation. So why this study has been done? Very little research has been conducted to investigate the protective effects of breastfeeding against the development of nephrotic syndrome. So aim of the study was to assess the relationship between the breastfeeding and the risk of developing nephrotic syndrome using the population-based birth cohort in Korea. Hypothesis is that exclusive breastfeeding might reduce the incidence of nephrotic syndrome. Data has been taken from the National Health Information Database in Korea, as well as National Screening Program for Infants and Children. This study was also approved by the Institutional Review Board of Ajayu University School of Medicine. This study followed the strengthening the reporting of the observational studies in epidemiology reporting guidelines. The inclusion criteria for these studies are all the children which are born between the January 1st, 2010 and December 31st, 2018, who underwent their first NHS-PIC examination at the age of 4 to 6 months of age. This is set as the index date and set as the date of examination. The exclusion criteria for this study are the children who are not responded to the breastfeeding questionnaire and children which are diagnosed with the complex chronic condition according to pediatric complex chronic condition classification version 2. Each child is followed until the occurrence of nephrotic syndrome 8 years post index date or death or December 31st, 2022, whichever occurred first. The NHS-PIC includes various questionnaires on the breastfeeding. They have primarily asked the question that what do you primarily feed your children? And the responders has to select 3 options. First is breast milk only, then second is formula milk, and third is mixed feeding, that is breast milk as well as formula milk. Outcome is primary occurrence of nephrotic disease, which is defined by the presence of ICD-10 code N04. In this study, the congenital nephrotic syndrome is excluded. So these are the characteristics is around 11. The results are that they have taken around 18,70,000 children, out of which 7,728 children not respond to the questionnaire on breastfeeding. Then around 74,000 children diagnosed with the complex chronic condition and 18 children diagnosed with the congenital nephrotic syndrome. So this is the risk of nephrotic syndrome according to breastfeeding and formula feeding. So we can see that overall the incidence rate in formula feeding is higher, that is around 7, and in exclusive breastfeeding it is around 5.9. Also the incidence rate in boys is more, that is 7.8, and in girls it is less. So this is the another chart which is showing the Kaplan-Meier curve, showing the probability and association between the exclusive breastfeeding and the incidence of nephrotic syndrome. Also, they have done the sensitivity analysis for this study. So the total population studied was around 17,87,000, out of which 6,12,000 were truly breastfed and 11,75,000 were formula fed. The median follow-up was done around 7.98 years, and they have seen that the incidence of nephrotic syndrome is around 6.6 per 1 lakh population. The Kaplan-Meier curves and the long-rank test also demonstrate that there was a significant difference in the incidence of nephrotic syndrome according to breastfeeding status. The exclusive breastfeeding was associated with the 20% lower risk of developing nephrotic syndrome. This is the Korean nationwide birth cohort study, which says that the exclusive breastfeeding for the first 4 to 6 months of life is associated with the 20% lower risk of developing nephrotic syndrome up to the 8 years of age. Subgroup analysis also shows that the significant risk reduction can be seen in case of boys. The distinctive feature of this study is the use of large-scale health care database in Korea. The mechanism by which the breast milk or breastfeeding has decreases the chances of nephrotic syndrome. There are 3 mechanisms. First is immunomodulative effect of breast milk. As we know that some studies suggest that the viral infection can trigger the development of nephrotic syndrome. So it can state that also the immunomodulative effect of breast milk can also decrease the incidence of nephrotic syndrome. Second mechanism is there is dysbiosis of gut microbes can be seen in case of nephrotic syndrome, as breast milk significantly affect the composition as well as the function of the early life gut microbes like bifidobacterium and lactobacillus species, which positively affect the gut health. So it is said that the nephrotic syndrome incidence can also be decreased by this positive effect of gut microbes. Third mechanism is the antioxidant and radical scavenging property of breast milk, because the reactive oxygen species can be implicated in the proteinuria, which can be seen in nephrotic syndrome. Though there are some limitations of this study, that the study is totally rely on the response given by caregivers, because there might be subjective finding of mixed feeding. Also, they have not reviewed the medical records. They have only rely on the ICD diagnosis. Sometimes the diagnosis can be incorrect, or the diagnosis has been made correct, but the code they have given is different. Even though the operational definition used for this outcome is variable, when we see the previous incidence reports, it is very unlikely that the operational definition used in this study was severely biased. So inference is that despite of the all limitations of this study significantly contributes to the understanding the protective effects of breastfeeding on the nephrotic syndrome, as this is a long-term observational study, which is the best approach to explore the causality. So my take-home message from this study is that this study reinforced the numerous benefits of breastfeeding on the developing immune system of the child. Breastfeeding is reported to prevent occurrence of various immune-related diseases. So as a pediatrician, we should give more emphasis on promoting the exclusive breastfeeding for the first 4 to 6 months of life. Thank you.
Thank you, Poonam ma'am. Dr. Pawan Deore sir.
Dr. Poonam, you can stop sharing.
Well done, well presented.
So, good evening, and thank you, Maha IP and Raigad IP for giving me this opportunity, and Dr. Poonam, excellent presentation. So, my take on this, first of all, I will just comment on the article first. The article is basically done is very well done, and considering that previously such all studies which were done were a retrospective cohort study, this is the first and the very unique study that it was a longitudinal observational study. Means it was started right from the infancy till the 8 years of age. So in given circumstances, currently probably this is the best study to prove the causality of the benefit between nephrotic syndrome and to decrease the nephrotic syndrome, how the breastfeeding is beneficial. And the study has very few limitations. Like the questionnaire which was used had only 3 options, whether it was exclusively breastfed or mixed feed or exclusively formula fed. So the duration of exclusive breastfeeding is mandatory, for 6 months. But how long that breastfeeding was continued, for 12 months it was given, or it was given for 18 months, that is not mentioned. So the study mentions this, that maybe they will do a better study in future, and they will improve the questionnaire saying that the breastfeeding was given for these many duration. And if it was a mixed feeding, then they will also mention that how much formula feed was used, and how much percentage, means how many times the formula feed were given. Probably they will improve on that. But under the given circumstances, this is the only good study to convince us that breastfeeding has benefits in preventing nephrotic syndrome by 20%. And another limitation of this study was that they followed up only till 8 years of age, which is because probably the typical nephrotic syndrome age category is up to 8 years of age. That's why they have not taken any further follow-up after 8 years of age. If they would have taken older children or continued the study beyond, if they continue, they will maybe find out that it has got even benefits beyond the children who are 8 years of age also. And the causality why it is beneficial is that breastfeeding has got benefits in preventing many atopic disorders as well as autoimmune disorders like inflammatory bowel disease, asthma, atopic dermatitis. In every autoimmune conditions, breastfeeding has been proven to be beneficial. And to mention about the cause and pathogenesis of nephrotic syndrome, the cause of nephrotic syndrome and the pathogenesis is that it is an IgE mediated, which is like B cell is involved, as well as regulatory T cells and helper T cells has got some dysfunction in children with nephrotic syndrome. And that is why it is an immune mediated disease. And breastfeeding, it is an like the study has also mentioned that it is a very excellent immunomodulator, and that's why it has some benefits in preventing nephrotic syndrome. And another point which I want to mention here is that one particular medicine called levamisole, which is used in nephrotic syndrome, especially in frequent relapsing nephrotic syndrome. All other medicines, including prednisolone, tacrolimus, cyclophosphamide, and mycophenolate mofetil, all are immunosuppressant. Levamisole is the only medicine which is immunomodulator, and it has the study which was first study which was done on levamisole was at Wadia Hospital by under the guidance of Dr. Kumud Mehta madam, and it was proven that it improves the function of helper T cells and regulatory T cells, and that's why levamisole has got very good role in syndrome. So very important in treatment of nephrotic syndrome, and if you are breastfeeding is also a very good way to give immunomodulation at very early infancy it starts. So I think this is a very good article which again stresses to all these points, and which this similar study can be replicated in India. Maybe we'll find out that if they have found out it is decreasing the incidence by 20%, maybe it is more beneficial in Indian scenarios.
Thank you so much, sir. That was an excellent presentation by Dr. and Dr. Pawan, sir. Thank you for the explanation. Dr. Srinivasan, sir, do you want to add something?
Yeah. Because except for the gene which causes some types of nephrotic syndrome. All the other things are due to immunological mechanism, and breastfeeding, and as correctly mentioned, the microbiome makes it so beneficial, and it prevents so many autoimmune disorders and inflammatory disorders, as just now mentioned, like inflammatory bowel disorders. Definitely, exclusive breastfeeding and continued breastfeeding beyond 2000 days is very important for this benefit. Thank you. Both presented very well, and both of them were very nicely commented by the experts.
Inashish, sir, do you want to comment something?
Well, good evening. At the outset, thank you right from the scientific team involving the Nimanti sir for selection the articles which are highly relevant to us. I must share with the entire audience over here that the articles are diligently selected by Monty sir 1 month in advance. So for example, we have the articles ready for the month of June 1st. That's number one. So that reflects the sincerity and the honesty on the part of our mentor Monty sir. Number one. The articles, both the articles which have been chosen are highly relevant to our society. That's very important. Number two. Number three, our speakers and experts. We all believe that they have done the justice to the core. Both the speakers have been to the point, very relevant and excellent presentation on their part. So also the Samir Bhai, who has been experienced in all, but I must compliment and congratulate to our Pawan, who is though being young, I mean to say you have mid-level and senior level, Samir comes in senior level, Pawan comes in mid-level. Having been on the mid-level and having, dissected the articles to this, we must compliment him. So this is from my end. And, I was just thinking for what the first of every month is remembered by me at least. So I am remembering for two reasons. The first of every month these days. Number one is the salary comes in the morning. Early morning I get a salary at 7 o'clock bank deposit. And second at 9 p.m. I have to be on the J&J. So this is the month first and the importance of J&J in our life. So we keep doing these things, and thanks to one and all for being the part of this wonderful journey over a period of time. That's from my end. Thank you.
Thank you so much, sir. Mohanty, sir, would you like to say something?
Thank you, Dr. Mins. I'm grateful to you for your comments. Dalwai is excellent. He's an expert in this field, and hats off to him. He has dissected it in Indian terms. But the idea of choosing this topic is different. Many of our parents are getting Americanized now. They're going to westernized lifestyle, and many parents that very limited children, they have this problem also. If they have such a child, what do they do? What do they do? So actually, we should make a consensus and demand with the government to develop a module so that we can take care of this in the national fora. At least some state support should be there. People who are having such children, they do not have any state support. And most of the things, if he going for counseling or OT for every month, or say 15 days every month, very costly. So this should be thought of as a social cause. IAP should take up as a cause and move with the government for a proper plan, structured plan, which is more compatible with Indian scenario. The other topic was, honestly, I'm saying the breastfeeding can be related to nephrotic syndrome. I had no idea. So while going through studying the journals, I got this topic and I found that is the only article published on breastfeeding service nephrotic syndrome. The only article I could see in the reference also. So in the prospective study, as Dr. Saab has pointed out, it's a very unique article. And Dr. Minhas has rightly pointed out, apart from this, if you can do some gut microbiota study in breastfeeding children with microbiota, gut microbiota as are in the flora, and which one of them protects that in nephrotic syndrome. If you can do it like this, maybe we can replicate this study in Indian scenario. And I think any of you can think of and join up together in a group. You can multicentric study. You can think of this nephrotic syndrome and breastfeeding. There is no dearth of cases. So subjects will be plenty. You can think of it. Thank you. I have nothing to say. The next month, Dr. Minaj, you have some topics you once suggested. Some topics from Pune. I think you are suggesting we can do that this time. We can defer the other ones.
Yes, sir. We can. What up? I mean, what do you want to have from my end, sir?
Nice. Any topic you were earlier? I think we have discussed. Have you any topic with this? You have some pressing topics. We can accommodate.
I can go. I have access to a lot of journals.
Sir.
I can go. Our organizations have the clinical key with us, so therein we have many journals.
Okay, okay. Then that's great. So we'll
Thank you,
tie
sir.
up. We'll
So
continue.
please, in next 2 days, please give us the topics.
Yeah,
And
will do.
sir, Pak Mode sir and Ganguly sir, do you want to add something?
One or two suggestions. Dr. Samir
Yes, sir.
said very nicely, and he always say very nicely. But the problem is that all people are the searching Googles and they just all get attracted to the Western things. So how can we put up our Indian things in the scenario? And what Nimen Moti sir said, yes, we should go ahead with the government or the what NGOs and whatever. So to bring out all the things about this, so the parents or the children, they should have some point of contact where they can get this all details. So how can it be devised? Samir, as I may be having the very good brain for that. So I hope so. He is taking cognizance of all these things and he will do wonderful things. I am very sure about it. The second thing, as Dr. Srinivasan sir is gracing this occasion, as he is free at the US, sir, if you can search any articles, journal is there or left?
Sir is there.
Sir is
Sir
there?
is there. Yeah.
I cannot see him. Srinivasan sir is there? He has left. I think so.
He has left, yeah.
He has left.
Okay.
So that message was for him because at present is the USA, and I thought ki any articles which are useful for with the journal journey was started. What are the articles which will be useful with the perspective of the general pediatrician to implement whatever can and whatever can learn the new thing. So and as he is not there, but then let us hope we can convey the message to him because he is free, so he can just search the articles for us and just share with us also for the further future episodes. And yes, Minaj is there. Minaj will be doing that.
And one thing with regard to government policies, it's easier said than done. Whenever you go to the government and their people over there in the government, they only ask one thing: what is the studies that you have? What is the evidence that you have? And without those hardcore evidence and the studies, nobody will listen to us. That's very clear. Samir Bhai will accept that. We have to have our own data. We have to have our own set of information. Then only they will listen to us. They want to implement. They want to be with us. But what are we going to present them unless we have the data with them? So they are receptive to us, but with data. Samir Bhai, you will agree to this?
Minaz, you have raised a very good point, but I'm very sure Samir has all the connections and probably he will all the amalgamate all the things, and he's the nearest person to the government, I can say.
And he is our team leader. He is the leader. He can take it to
Yes.
the government. He is
Yes.
young, enthusiastic, dynamic, and full faith in him. You can go to the government through him.
Mohanty sir, the Samir, I believe that already has done a lot of work with regard to NCECD. So there they have come out a lot of papers. They're in the process of doing that, and probably that they're taking it to the government. If I believe that is one that they are doing at their level. So we can take up we can take the help of our president, our Sanjay Patmode also from the state Maharashtra. It's something we can do with regard to research also. How we can talk about. That's one thing we can consider, Sanjay Bhau. With
Yes,
the people and all, and we always been there as part of it. Whatever you want, our support for that.
Yes,
See,
Minas, Nagpur has very good connections, and Dr. Sanjay, you will be helping us.
no, we do. All people have said the right thing in the right perspective, and everything is agreed. But for the, as sir has said, ki Samir sir has to go further. Then we'll have to give some national post to him so that he can represent internationally and put his thoughts or research, so that once he gets that opportunity and once he put, I think that will be the best way to do the things, make it means accept worldwide, and that can be made, means Indian studies are also, as far as they're done by the wonderful people, they are also very good and very well research, but material is already been there with him. But for this, we'll have to help him in his venture of means making him the president elect. Excellent. Thank you. Thank you.
Thank you.
Thank you.
Madam is there. Now her comments, please. She is here. Yeah.
Dr.
Bela.
Bela Verma is there, madam. You can also suggest some good articles. You are reading lot of articles. Dr. Bela Verma, madam, is there.
You can call her.
Yes, sure. I also was there for one of the journal journeys last year, I think, but
Yes.
so where some young pediatrician had presented, and I think on ORS, was it?
Yes.
And yeah, something about that, I think. So yes, good articles, but pertaining to our Indian scenarios,
Yes.
where their studies will be extrapolated for our population and they will be useful for us. Means, if I read an article which tells me what I can do more for, say, bronchiolitis or asthma, and I can do it in my hospital, I think such articles are most welcome.
Yes.
And I will definitely keep a watch for any good article. We have regular journal readings in our college as part of PG teaching activity, and some of them were very good articles. So I will definitely share with you all.
Yes, thank you, madam. And for the next month, already sir has already said 2 articles. For next month, 2 articles will be shared by Minas. For under 2 months after, 2 articles will be shared by Dr. Bela, madam. You have to help our Mohanty sir in all this searching the articles, please, because you are in the institutions and you are well attached to all these journals and accessibility to the journal. So please help us. Request to Bela, madam, as well as Minas Sheikh. Thank you very much.
Definitely.
Thank you, everybody. Thank you.
Thank you. Excellent.
Thank you.
Yeah.
Thank you, everybody.
So
Thank you,
today
Sanjay
we
ma'am.
had a-
Thank you, sir.
Today we had a
Thanks,
wonderful
Nilima.
session.
Thank you, Neha.
And in
Yeah,
the
thanks,
chat
Shilpa.
box, no
And
questions are
Shilpa
there
for wonderful.
except for the huge appreciations for our presenters and experts. So now I hand over to Dr. Shilpa for the vote of thanks. Over to you, Shilpa.
Thank you.
Shilpa, you
Please
are mute.
unmute, Shilpa.
It was a wonderful journal journey session. We had great experts and with great topics. I thank our Maha-AP dignitaries, Dr. Sanjay Pakmode sir, Dr. Sanjay Deshmukh sir, Dr. Hemant Gangulia sir. I thank our presenters, Dr. Nilima Bhandarkar ma'am, Dr. Poonam Muste ma'am, and our experts, Dr. Samir Dalwai sir, Dr. Pawan Deore sir. Other dignitaries, Dr. Niman Mohanty sir, thank you so much for the support always. Dr. Chitra Kulkarni ma'am, Minas Sheikh sir, Subramaniam sir, Dr. Bela Verma ma'am, thank you for joining us and being a part of the discussions. I thank my co-moderator, Dr. Neha Singh ma'am, for always being there as a support, and the technical team, Dr. Pallavi madam. So
She has become Dr. Pallavi now.
it comes in the flow, doctor. Yeah, thank you so much, everyone.
Dr.